All right, take a few moments to read the question and pick an answer, and then we'll go through the answers together. All right, so our question reads that a 79-year-old man presents to the emergency department for increased confusion and irritability. His wife states that the patient has not been acting like himself for the past several days, and this morning was unable to carry on a simple conversation with her. Okay, so we have this picture of an elderly man, 79 years old. He's got confusion and irritability just over the past several days. When I think of confusion and irritability, especially in an elderly patient, things that are on my differential are things like delirium, maybe Alzheimer's disease, any of the dementias, maybe a vascular dementia, maybe even something substance related, maybe a Wernicke's, maybe a metabolic cause, potentially an electrolyte abnormality. So I think a great key here to keep in mind is the chronicity. So when we're talking about the past several days, that really rules out something like Alzheimer's disease, because that would of course have a more chronic progression. This seems to be more of an acute issue. Certainly vascular dementia is still on our differential. Certainly delirium is still on our differential. And when thinking about the causes of acute delirium, I like to use the MIST framework. So the M in MIST stands for metabolic causes. That could be kidney failure leading to uremia, anything like that. The I stands for infectious causes. So any infection, a high fever can certainly cause delirium. S stands for structural. So this would be things like, do we have a subdural hematoma? Do we have a bump to the head? A vascular accident that could be causing an acute change in mental status. And then the T stands for toxin. And I like to think about this one in two categories. Toxins can certainly be recreational substances like alcohol or opioids or withdrawal from these substances. It can also be just new medications that we have given our patients. So antihistamines are definitely known to cause delirium in our elderly patients, many other drugs that cross the blood-brain barrier. So these should all be on your list when you're thinking about confusion in an elderly person. And of course, this is an incredibly broad differential. So we're going to need to continue reading our question. The question goes on and it says, the patient's wife notes that the patient has had increased watery, foul-smelling diarrhea, requiring him to be near a toilet at all times. So definitely some increased urgency here. The patient's wife states that these symptoms started after their recent travel to Iowa to visit the patient's grandchildren, but denies him having any additional symptoms or ill contacts. When I think about differentiating between different causes of diarrhea, there's a couple questions that I always like to ask. Number one, is it bloody? That's a great question to differentiate between things like Crohn's or ulcerative colitis, or maybe other infectious causes that cause more of a bloody diarrhea like Shigella. It's also important to know if it is watery or foul smelling. Certainly when I think about watery, foul smelling diarrhea, I usually think about C. diff. There's a very distinctive smell with C. diff that will often show up in your board style questions. And then when I think about ill contacts and his recent travel, those are great screening questions to ask about if a patient might have a traveler's diarrhea or a diarrhea contracted from food. So, the chronicity, if it happens on the same day as eating food outside, it might be something like a Staph aureus, those preformed toxins. Of course, if this patient has traveled and then eaten at a restaurant, they might have an E. coli. I think it's really important when they say that there's no other ill contacts. I think that makes it a little bit less likely that we have one of these foodborne illnesses. So that would be lower on my differential here, but with the watery, foul-smelling diarrhea and the urgency, certainly I'd be thinking about C. diff. The question stem goes on to read that the patient's medications include simvastatin and aspirin. His wife reports that he completed a course of ciprofloxacin and azithromycin approximately 1 month ago to treat pneumonia. And this here is interesting because in the setting of recent antibiotic use, we know that is one of the risk factors for developing C. diff, and that coupled with our watery, foul-smelling diarrhea, those are definitely ringing alarm bells for me, thinking that C. diff is likely going to play a role in us answering this question. The question continues to read that in the emergency department, our patient is started on IV fluids and his condition initially improves. 2 hours later, he experiences acute onset dysphagia and new weakness in his lower extremities. Deep tendon reflexes are noted to be increased at this time. What is the most likely cause of the patient's worsening condition? So we have a picture of this patient who we're pretty sure has C. diff. Our patient comes into the ER for confusion and irritability. He's given IV fluids and his condition initially improves, but after 2 hours, he begins to experience this dysphagia, these new weakness in his lower extremities. Deep tendon reflexes are increased, so definitely some neurological symptoms symptoms, and we want to know the most likely cause of this patient's worsening condition. When I think about a patient and they're a little bit confused and irritable, they're started on IV fluids and the IV fluids help, what that tells me is that this was likely a dehydration problem. So because this patient has so much diarrhea, they likely became dehydrated, and additionally, because they are excreting all of their electrolytes, they're also probably hyponatremic. And as we know, hyponatremia can definitely cause confusion and irritability. It makes sense with the chronicity of this patient's symptoms. That's kind of the clinical picture here. When you start on IV fluids, it makes sense that his condition initially improves, right? Because the treatment for our hypovolemic hyponatremia would be to start IV fluids and start to replete some of that salt. As we're repleting that salt, however, 2 hours later, our patient begins to experience acute onset dysphagia, new weakness in his lower extremities, and his deep tendon reflexes are noted to be increased at this time. So all these symptoms taken together definitely sound like we have a neurological problem, right? I think one of the key clues they give you here is that the deep tendon reflexes are noted to be increased at this time. That tells me that this is most likely an upper motor neuron problem instead of a lower motor neuron problem. And I think it's incredibly important to differentiate between upper motor neuron versus lower motor neuron when we're approaching these neurological problems, because it can be incredibly helpful for you to help sort out your differential. So we have this upper motor neuron problem, and the question asks us what is the most likely cause of this patient's worsening condition. Well, taken together with the fact that we're rapidly correcting a patient's sodium, that he improves in the ED once we start our IV fluids and then begins to experience neurological symptoms, this is a classic presentation for osmotic demyelination syndrome. Osmotic demyelination syndrome, remember, is that syndrome that can occur when we replete a patient's sodium too quickly, causing all of the fluid to rush out of the brain cells, specifically those oligodendrocytes, which are our myelinating cells, and then causing demyelination and upper motor neuron damage, which would lead to these symptoms that we see here, the dysphagia, maybe new weakness in lower extremities, and increased deep tendon reflexes. That's really important because this is an upper motor neuron problem. If we had a lower motor neuron problem, we would see decreased deep tendon reflexes, and that's a really important key differentiating factor here. So now we have a great idea about what's going on in this problem. We know that we're talking about osmotic demyelination syndrome, so let's go through our answer choices and see what fits this pathology. First, our answer choice is avulsion of nerve roots from the spinal cord. That doesn't really fit with this picture. Avulsion of the nerve roots from the spinal cord usually occurs due to a traumatic event. There has to be some sort of history of trauma. Our patient was sitting in an ED bed. He did not have any of these neurological symptoms when he presented to the ED and did not experience a traumatic event in the intervening time. So that really would not make sense here, and A would not be a good answer to choose. Our second option is autoimmune destruction of the myelin sheath. And these are classic buzzwords for Guillain-Barré syndrome. And Guillain-Barré syndrome could make sense, right? Because we had a patient with C. diff, they had an infection, and now they're having these neurological symptoms. However, it doesn't really make sense with the time course. Guillain-Barré syndrome is very gradual. It does not just appear within 2 hours. Additionally, it's usually associated with more peripheral nerves, so the deep tendon reflexes shouldn't really be increased. There are a lot of variants, so that's not 100% a great indicator, but it makes it a little bit less likely here. And then finally, because we know our patient initially improved with IV fluids, that is just way more highly suspicious for a hyponatremia, which of course can result in osmotic demyelination syndrome and doesn't really fit with this picture of Guillain-Barré. So this would also not be a great answer to choose on this question. The third answer is accumulation of amyloid beta protein deposits. This is a classic way that they will try to indicate to you that they are talking about Alzheimer's disease. However, this doesn't really fit with our picture because we have this time course where our patient has only been confused for the past several days. With Alzheimer's disease, it's a much more chronic progression. Additionally, Alzheimer's disease does not improve with IV fluids, so that's a great indicator that we're not talking about a progressive dementia here. So option C would not be a great one to choose. Option D, we're talking about cerebral apoptosis and shrinkage of our oligodendrocytes. Of course, this is going to be the correct answer, and this is a classic way that they're going to test you on osmotic demyelination syndrome. So what's happening is we are having this shrinkage of our oligodendrocytes because all of the water is flowing out of them in response to the increased salt in the surroundings. This is going to lead to cerebral apoptosis. This cerebral apoptosis, or cell death of our neurons, is what is going to lead to some of those neurological symptoms that we see in our question stem, and this of course would be the best answer to choose here. And then finally, our last answer disorder, antibodies against postsynaptic acetylcholine receptors. This is a classic indicator for myasthenia gravis. Myasthenia gravis, again, is not going to present with increased deep tendon reflexes. It's going to be more consistent with fatigability, so increased muscle weakness after muscle use. This also would not account for our patient's confusion or improvement on IV fluids, so this is not going to be the correct answer to choose either. I hope after watching this video, it's very clear why we chose answer D to answer this question. Some high-yield takeaways that I want you guys to be aware of here are when answering questions like these, where you have a lot of things that could be on your differential, really pay attention to the time course and the chronicity of onset, because that's going to be a great way to cross a bunch of things off your differential right away. No matter what the differential is, if we're talking about diarrhea, for example, that's a great way to differentiate between traveler's diarrhea, which would only last for maybe 10 days, or something like C. diff that could go on for up to months. Talking about confusion, which we also talked about in this video, again, it's a great way to differentiate between, is this an acute delirium or is this a progressive dementia or something like that. So really pay attention to the time course of all the different pathologies you learn about and the pathologies that they give you on step 1. And then finally, when answering these types of questions, a lot of times on step 1, the answer choices that they give you will not directly indicate which disease they're talking about. So it's a great idea to get familiar with some of the underlying basic science behind these diseases. Understanding the basic science will help you look through these answer choices and realize from the description what diseases they're talking about, which will help you get the right answer on test day. Now that's all I have for you on this video. Thanks, and I'll see you next time.